All right, welcome everyone to today's TCARM speaker series. My name is Vin. I'm one of the education theme leads, and I'm a fifth year MD PhD candidate here at U of T. So to start off, we'll begin with a land acknowledgement. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. A little bit about us: the Temerty Center for AI Research and Education in Medicine at the University of Toronto has been made possible by the generous donation of the Temerty family. TCARM is an interdepartmental center that serves as a focal point for collaboration among healthcare providers, trainees, researchers, computer scientists, engineers, and industry. And our goal is to transform health through AI. Quickly, I'll remind you that this event is CPD accredited, and to obtain your CPD credit, please complete the evaluation form that we will email to all attendees following the event. And don't forget to provide your name and email address on the evaluation form. Please use the question and answer function in Zoom to submit your questions for Dr. Hodaie. She will answer them during the discussion portion of this webinar. Also, this event is being live tweeted, so please follow along using the hashtag TemertyTalks. Now I'll welcome Dr. Hodaie onto the screen here. Dr. Hodaie is a neurosurgeon and professor of surgery at the University of Toronto's Temerty Faculty of Medicine. Her research focuses primarily on the study of neuropathic pain, and specifically trigeminal neuralgia, the most common and most severe form of chronic facial pain. Dr. Hodaie's research strategy has focused on the study of advanced brain imaging, including neural microstructure and how this contributes to pain, its diagnosis, as well as prediction of surgical outcomes using brain imaging. Dr. Hodaie and her team are part of TCARM and have focused on the role of AI in developing models that can bring greater objectivity in the understanding of pain. In 2021, Dr. Hodaie was awarded a CFAR Temerty Innovation Catalyst Grant. Congratulations once again on that, Dr. Hodaie, and we are delighted to have her speak this afternoon. So I welcome you to share your screen, provide your talk, and I will see you back in about 40 minutes, and then we'll kick off with questions then.
And yes, thank you very much for introducing me and for allowing me to speak today. It really is a pleasure to be part of this series. I'm just going to share my screen and get started. I hope you can see my screen okay. All right, so I bring you greetings from our site at the Toronto Western Hospital, where we try to look after patients with neurosurgical conditions and also understand better what we can do to help patients. So I want to maybe start by talking a little bit about some areas that our audience may not be directly familiar with. One of them is the field of functional neurosurgery. So if I were to show you this picture, and even if you're not accustomed to seeing MRIs of the brain, you can probably see that there's something here, if you can see my mouse, that does not quite look normal, and that is a disorder or structure. That's a brain tumor. At the same time, we can have MRIs that are perfectly normal, structurally speaking, if we look at them, such as the one that you see on your right. But the patient might have a disorder of function instead. So for instance, if I were to tell you that this patient has some form of movement disorder, then the MRI might be entirely normal, such as this. If I were to tell you that this patient has epilepsy or pain, the same thing. So the field of functional neurosurgery focuses on the understanding of disorders that we presume to be disorders of function, not so much of a structure, and of course, treatment of those disorders with surgery. So with that context, I want to share with you also the great dilemma of pain. So take a look at this X-ray of someone's spine, and you can think of what this patient must have gone through. The reality is that pain is a common human experience. It is subjective. So generally, we ask patients to describe their pain to us. We don't really have a test that is able to either measure or visualize their pain, save by corollaries such as this X-ray. And we know also that pain has a discriminative sensory component versus an emotional component. So for instance, when we have a small paper cut, our skin is cut, we can feel the burn, we can feel the discomfort, but oftentimes it doesn't affect us emotionally. There's other pain syndromes or pain events that affect us primarily on the emotional category and less on the discriminative sensory component. But these two are well known, and they're attached in different measures to the experience of pain. So all of this has implications for research, diagnosis, as well as treatment. So here I want to also introduce the concept of this disorder called trigeminal neuralgia, which is a very severe form of facial neuropathic pain. Patients express that they have sudden unexpected shocks or attacks of pain in the face. These are typically on only one side of the face, and they're associated with mild sensory triggers. So for instance, a gentle touch to the face, brushing your teeth, talking or chewing just brings this incredibly intense attack of pain. And the number of expressions that patients use to describe this pain is quite telling. Some patients describe it as a surge of 10,000 volts of power into their face. I don't know that any of us is able to feel that and live to tell the tale. Other patients have described it as a sharp, jagged knife that is connected to an outlet on the wall. And perhaps one of the most telling descriptions was a patient of mine who said that he was walking outside when it was snowing, and a single snowflake landed on his cheek. And that resulted in a pain so severe that he literally had to hold on to a lamppost for 10 minutes before he could start walking again. So that's the level of pain that these patients have to endure. And before there was adequate treatment for these patients, their conditions was quite dire. In fact, I will take you back to historical descriptions of trigeminal neuralgia. And I think this is actually very telling. Even if you're not particularly interested in history, I think it's good to know the context of where we have been and where we come from. Initially, the famous physician Galen described this condition, and first he linked it to the facial nerve, which is of course the incorrect nerve responsible for this pain, but not much was done about it until this fellow by the name of Maréchal, who was surgeon to Louis XIV, and look at all his tools hanging from his belt and from his elbows and so on, decided to tackle this problem, and he approached the facial nerve, which resulted in paralysis. So at that point, really not much was done surgically, and treatment consisted primarily of all kinds of medical treatments, quinine, arsenic, bromides, etc., without too much success. And then slowly in the 1800s, more operations, more approaches were done. And of course, surgery was not particularly advanced at the time. We did not have microscopes. Control of bleeding was difficult. Anesthesia was a major issue. And the vast majority of the procedures were dedicated to either cutting the nerve, cutting the ganglion, which is a collection of cell bodies that is part of the trigeminal system, or even for patients that had pain, for instance, in the jaw, radiating on the branch of the trigeminal nerve that supplies a sensation to the jaw, excision of the jaw, and so on. So which is quite involved. Sir Victor Horsley, a very famous neurosurgeon and one who advanced the field tremendously, has a very nice description of a procedure that he performed to divide the fifth nerve, the trigeminal nerve, behind the ganglion. He performed this procedure well over 100 years ago in 1890. And he started by resecting the zygoma and then opening the lining of the brain, the dura, finding the nerve. He put a hook around the nerve, and he sectioned it, but the patient actually never woke up. Now, we don't know exactly what happened to that case. We know that there was an autopsy afterwards, and there wasn't a technical issue. There was no hemorrhage. But either it was an anesthetic problem or the patient was so emaciated from not being able to eat and being so nutritionally poor that he could not survive the operation, or perhaps a combination of the above. So you can imagine how difficult this might be for both patients to endure this and for surgeons trying to help these patients. At the end of the day, the current knowledge of this condition links pain to the proximity and potential pressure and compression of a blood vessel onto the trigeminal nerve, depicted pictorially as you see here. So we have the nerve here, a trigeminal nerve or cranial nerve 5 in yellow, and we have a blood vessel that is either nearby, which is, it lives there, it's supposed to be there, starts contacting the nerve, in some cases compresses the nerve, and in some cases, frankly, distorts the nerve. And most of what we do is dealing with this concept of neurovascular compression. So we either use procedures such as microvascular decompression, where we physically go to this nerve. This is a brain operation. I'll show you a clip very soon. We physically go, and with a microscope, we remove the compression of the nerve, and we make sure that there's no contact between these two structures, and that is actually very effective in settling the pain. Or we use something called gamma knife radiosurgery, where we interfere essentially with how signal goes back and forth in the nerve by delivering a very sharp but tiny beam of radiation onto the nerve. And this is roughly the area where we work. So you can see the structure of the brain, and deep to the brain, we have the brainstem, as well as over here in the cisterns, we see the two trigeminal nerves. So the trigeminal nerves are not very large. They are, to be generous, about 3, maybe 4 millimeters in width, definitely not bigger than that. And their course in the CSF space, in the fluid space, can be variable. It can be maybe in the order of 5 or 6 millimeters, or maybe a little bit longer, and sometimes even shorter. So this is our point of intervention for our procedures. And this is how we visualize patients. So they often, obviously nowadays, always have an MRI. And on the MRI, we're able to visualize the nerves. And then we examine to see what's happening with these nerves. So for instance, in these instances, you see that the nerve is coursing through the CSF space, which is seen as white or light gray. And then we see the nerve coming out of the pons. And we see the structure that is crossing over it, looks like it's pushing it a little bit. So that's a blood vessel. I would say that on this side, things are not quite normal either, rather than the nerve coursing straight out. I hope you can see my mic, yes? Rather than coursing straight out, it's sort of twists a bit. We only have one image, but again, we examine these nerves to make sure that whether there is compression around them and whether we can approach that. And surgery involves in approaching this corridor towards which the blue arrow points. So this is called the cerebellopontine angle. And it's important because in this angle, there live many, many cranial nerves that we need intact and happy and healthy so that we can function properly. So just a few millimeters down the line from where the trigeminal nerve lives, sit cranial nerves 7 and 8 that allow us to move our face and to hear, and so on and so forth. So these are very important structures within the area of the cerebellopontine angle, as well as the brainstem, that we need good and healthy. So I just want to show you a brief clip of a procedure that we do, the microvascular decompression that I mentioned to you, and to just impart upon you what it means to actually go down there and get this vessel out of the way and what it is that we do. This is a view through the microscope. You see this white sponge here. The width of the sponge is about 1 centimeter. So that puts into context what structures we're looking at. Over here, the yellow structure that you see is the trigeminal nerve. And you can see 2 yellow bars to the right of the screen. And these are cranial nerves 7 and 8. So you see their proximity as well. Okay, so take a look. We are beating with the heart. So you see the cerebrospinal fluid, and you can see that the nerve appears a little bit dented. So I'm reaching out here, and there's a blood vessel that's essentially stuck underneath. You can see the pons just below where we are, and there is a compression. So the compression is now removed, the nerve is now flatter and it's not stretched so much. And again, the pons just distal to where we are looking at. And then we put a piece of Teflon that takes away the contact and the pressure between these two structures. And this effectively completes the operation. There's other procedures as well. I talked very briefly about gamma knife radiosurgery, where we send a beam of radiation onto the nerve. We don't kill the nerve, but we are able to interfere with how signals go back and forth, and that results in relief for patients. And this is done really based on imaging alone. We don't enter the brain. It's a day procedure, and the patients are able to go home the same day. We place what we call a shot right onto the nerve, and then the treatment is delivered. So let me take you back and ask you to think again about this concept of neurovascular compression, and hold that. I will ask you as I speak today to hold selected concepts with you so that at the end we tie them all into a box, and hopefully it'll all make sense. So remember that I told you about this blood vessel pushing on the nerve, and sometimes it compresses the nerve, sometimes it distorts the nerve. But let's think about it. Is the blood vessel at fault here? And this slowly becomes an important point to notice, because we know that if I were to MRI, say 100 people that walked through the door of the hospital this morning, about 20% of them that have no symptoms, I'm just imaging them, will show evidence of neurovascular compression, but they have no pain. So this is one important query. We also know that not all patients with trigeminal neuralgia have evidence of categorical neurovascular compression on imaging. In fact, about almost 40% of patients with trigeminal neuralgia don't show this degree of neurovascular compression that one would see on the MRI, such as what I showed you before. At the same time, a good number of patients with trigeminal neuralgia have bilateral neurovascular compression in imaging, but the pain is uniformly and overwhelmingly unilateral. So it is my view, and this is perhaps one of the matches that fueled the fire of our research, that we have focused for too long on studying the blood vessel when we study trigeminal neuralgia, because studying the nerve has been so difficult. But in fact, the blood vessel is not directly at fault. And this has, focusing on the blood vessel has biased our understanding of trigeminal neuralgia. And we're looking in the wrong place. We have to look at the nerve, we have to understand the nerve, and we have to understand the connections of the trigeminal system so that we can make sense of what results in this disorder and how we can help our patients. So in order to answer this, I focused on the use of advanced brain imaging so that we could have better ways to focus on the understanding of the neural microstructure and understand, I use the term loosely, the changes that are associated with either the trigeminal nerve, the brainstem, and the brain, and also understand whether these potential abnormalities are sufficiently unique to characterize this disorder and what they actually mean. And hopefully, by having answers to some of these questions, then we'll be able to come up with a plan to have a better approach and better understanding of this condition and helping our patients. So let's start with some first steps, and these steps inform us as to what is going on when the brain is in pain. We focus on a number of techniques, and these include diffusion tensor imaging of both the trigeminal nerve as well as the brainstem fibers of the trigeminal system, cortical thickness analysis to look at brain gray matter, subcortical gray matter analysis to look at different parts of the brain that we can measure the volume to, white matter analysis of the brain as well as volumetric analysis of the hippocampus. So I'll go through some of these studies for you, but let me just briefly talk about these techniques because they're very relevant to what we do. The first one is diffusion tensor imaging, which uses the information of, okay, so sorry about that. The internet's just suddenly decided to stop working. Okay, let me just reshare my screen. Okay, so I'll pick up where I was before. So I was mentioning that essentially an isotropic diffusion relates to the concept of unequal flow of water through fibers. So for instance, if we drop a ball of ink on Kleenex, which is fairly uniform throughout, we see that ink flows equally in every direction, but on newspaper, which is much more fibrous, we see a different pattern all together. So we use this to image the fibers of the brain, and we study it as well with metrics, including fractional anisotropy and different types of diffusivities, so that we can understand what could be the changes in the expected flow and what these refer to. So for us to see changes in mean diffusivity, we typically relate that to neuroinflammation. Axial diffusivity might represent axonal changes, and radial diffusivity would represent changes related to myelin. So in this way, and by using information from diffusion tensor imaging, we're actually able to gain understanding of neural microstructure and use that to investigate different processes. In this way, we are also able to image the trigeminal nerve fibers and look at the fibers that I showed you on the MRI and go beyond the conventional method of imaging, which would be just essentially black and white or grayscale view of the brain, and instead look at the fibers directly, look at what those fibers might represent, and take metrics from different areas of the nerve to study them better. Another technique that we focus on is cortical thickness imaging. So this shows you a picture of the brain that has been tessellated, which means it's been broken into the smallest geometrical structures, primarily, but not uniquely, triangles. And by doing this and stacking different brains on top of each other and really splitting all of these as if it were a crumpled rug, opening it up all together, we're able to retain information of all these tessellated areas and keep information of the different peaks and valleys in the brain, and also measure both surface area as well as the thickness of the cortex. And this is done through a process that involves primarily post-processing of brain MRIs, where we strip the skull and we strip everything that is not brain, and then we have different types of rendering, and we can use the whole hemisphere, we can use just part of a hemisphere, whatever it is that we intend to use to answer the question at hand. There comes a problem though, and that is when we use diffusion tensor imaging, we just don't have one set of fibers to study. Most of the brain involves regions of crossing fibers, sometimes rather complex set of crossing fibers. So the most common form of diffusion tensor imaging just gives us an approximation of the dominant set of fibers or the dominant flow of water in the voxel where we're studying, and that is insufficient. So part of our work has also been involved in using multi-tensor methods of imaging that give us a better approximation of exactly what is going on in the region of interest, and make sure that we don't miss changes that are relevant to us, particularly because some of the fibers that we deal with are small. So for instance, if we look at a conventional type of imaging, which you can see in the figure at the top, you see the fibers of the trigeminal system that go towards the top of the screen. And then you see a big bundle of cerebellar peduncle that takes over and comes in the way of us visualizing the trigeminal fibers within the brainstem, because the cerebellar peduncle is much bigger and is dominant, and it won't let us see the rest. In the panel below, figure B, we have used multi-tensor methods, and in this way, even though we are still seeing the cerebellar peduncular fibers, we are now able to visualize the trigeminal fibers and therefore study them. And therefore, an important knowledge of anatomy is relevant here, so that we pick the correct structure to study and work with. So this has occupied quite a lot of our time. How do we truly image the trigeminal fibers properly in trigeminal neuralgia? How do we label them? Where do we take the information from? How do we subdivide these areas into, for instance, the sternal segment? What exactly constitutes the root entry zone, pontine segment, etc. So that is elements of work that initially went into understanding of how we apply these methods of imaging. And from then on, a number of paths of inquiry opened up that I will share with you. The first one is, are there microstructural abnormalities in the trigeminal nerve when we look at patients with trigeminal neuralgia? Is there neuroanatomical cortical changes in brain gray matter? What about white matter? Are these abnormalities potentially dynamic? Do they change, for instance, when patient has pain and when patients don't have pain? And are they restricted to the neocortex, or do we see them elsewhere, for instance? So the very first observation was, in fact, the ability to differentiate that the root entry zone of patients with trigeminal neuralgia is different than those with healthy controls. This paper goes back a while now, but it really cemented this field. And in this study, we did demonstrate that the trigeminal nerves are not normal. And interestingly, we observed that the contralateral trigeminal nerve is not normal either, but is not as abnormal as the affected trigeminal nerve. So remember, a few slides back, I told you that a vast majority of patients with trigeminal neuralgia, about 40% of them, have bilateral neurovascular compression. Well, we do see evidence that both nerves are not quite normal in trigeminal neuralgia, but one of them is affected more than another. We were also able to visualize certain areas where that are important in the modulation of pain and perception of pain to be abnormal in patients that have trigeminal neuralgia compared with healthy controls. There were also key areas in the subcortical structures, such as the thalamus, and periaqueductal gray, areas that are well known and important in pain that were abnormal in patients with trigeminal neuralgia. Well, this was not restricted to gray matter. We saw abnormalities as well in white matter. You see, for instance, the area of the corpus callosum, a very large commissural, our largest commissural bundle that allows the connection of both hemispheres. And there are areas where clearly we see that there's differences between patients that have trigeminal neuralgia and our healthy controls. Interestingly, when we looked at these areas, at the gray matter areas, at least in patients with trigeminal neuralgia, once they have had surgery and once they were free of pain, we see that in fact certain anatomical areas normalize in thickness. And the key one that we saw at 6 months after effective treatment was normalization of the insula, a most important and relevant structure to how we perceive our bodies. And we saw that patients that had treatment that was not effective for them, in fact, this normalization did not take place, whereas patients that had effective treatment did have normalization. So this again points to these changes being dynamic and not static. An important observation came recently as well from our studies of the human hippocampus. The hippocampus, as you know, is crucial to the concept of memory and attention. And this is something that patients with trigeminal neuralgia routinely complain of. They say, you know what, I have so much pain, it's hard for me to focus. People will start the conversation and halfway through, I forget what we talked about. I might not be able to figure out what I'm doing at work, and it might be difficult for them. And routinely, we say, oh, it's probably the medications, probably the medications. Well, we looked at these patients, and it turns out that the hippocampus is selectively affected in patients with trigeminal neuralgia, such that some subfields, but not all, are smaller in patients that have this condition. And again, these normalize when patients have pain relief. So overall, this path of inquiry points to profound signatures of trigeminal neuralgia in the brain, affecting cortical, subcortical gray matter, white matter, the root entry zone of the trigeminal nerve. It points to the trigeminal nerve, the trigeminal condition, neuralgia condition being affected bilaterally, even though the expression of the pain is unilateral. We talked about the dynamic changes of gray matter and the potential reversal that we see of these changes, speaking of possibly some level of hierarchy or roles of specific neuroanatomical sites. So let me now point to a second path of inquiry, and that is, are there conditions that we call secondary trigeminal neuralgia conditions? So they're not directly associated with that vessel pushing into the nerve, where the brain might also be abnormal. How can these inform us of this pain? So here I want to talk about two conditions, multiple sclerosis, as well as a recently described syndrome called single ponting lesion trigeminal neuralgia that we described a few years ago. So the first one is multiple sclerosis. These patients have a much higher likelihood of having trigeminal neuralgia pain, which is called MS-related trigeminal neuralgia, sometimes distinguishing the expression of pain between classical trigeminal neuralgia and MS-related is indistinguishable. They have a very, very similar expression of pain, but we know that in patients with MS, the problem is elsewhere. The problem is not a blood vessel pushing on a nerve. The problem is sclerotic plaques, typically within the fibers of the trigeminal system in the brainstem. So we wanted to find out whether we're able to distinguish, based on imaging, between one set of patients, namely classical trigeminal neuralgia, and those that have MS-related trigeminal neuralgia. And by doing that, we looked at the fibers of the trigeminal nerve, but also the fibers within the brainstem to see whether we could find a relationship between an MS plaque and the trigeminal fibers. And in fact, we can, such that the perilesional component of the trigeminal fibers, those that are lying just besides the lesion, demonstrate, and here there's a bar here, demonstrate FA changes, fractional anisotropy changes, that points to this abnormality relating to the pain. And when we measure it using metrics, we find that this is related to measures of myelin and therefore radial diffusivity. We're also able to look at the plaques within the brainstem in patients with trigeminal neuralgia and study these in relationship with the trigeminal fibers to understand how can we have plaques that are active and maybe some that are not active, and understand what results in pain in these patients. And based on that, we developed this technique of standardizing T1 and T2 ratio to estimate the degree of demyelination in vivo. And I'm very happy to say that one of our summer students who has a TCARM award for her summer project, Rose Yakubov, is working on this project to understand now the difference between MS patients that don't have trigeminal neuralgia and those that do. So hopefully in an upcoming webinar, we'll be able to share some of those results with you. The other condition that I want to talk to you about is this unique condition called solitary trigeminal neuralgia associated with a solitary ponting lesion, a definition of a new syndrome. So in this syndrome, and in the very large number of patients that we look after, we found that a small collection of patients have this unique tiny lesion in what we thought would be the fibers of the trigeminal nerve within the brainstem. The rest of the brain is actually perfectly fine. So these patients do not have other conditions. They do not meet the criteria of multiple sclerosis. They do not have any symptoms relating to other conditions. They just have this unique single punched out lesion within the fibers of the pons, as you see here. And this lesion is quite obvious. As you can see, is sort of very, very dark here. And we can't, on the common lesions where, on the common sequences where we see MS plaques, we can't really see that so well, but you can distinguish them here. We have this condition. We have patients with classical trigeminal neuralgia that have no lesions. And then we have MS patients that have, of course, multiple lesions. So very, very unique. And when we looked at advanced methods of imaging, we were able to map these lesions to the trigeminal fibers within the brainstem. And by taking metrics from these sites, we compared them to patients that have MS, and we were able to show that, in fact, these are not the typical sclerotic lesions that we see with multiple sclerosis, but they're different altogether. We don't know what the etiology of these patients' lesions are, but it has a great impact in fact, on how we understand pain that relates to changes within the brainstem fibers of the trigeminal nerve and how it impacts our treatment. So I will talk about this very shortly, but patients that have classical trigeminal neuralgia generally have about 85% chances of being pain-free after treatment. If patients have multiple sclerosis, they have about 70% chance of being pain-free. If they have this condition of single ponting lesion, they have about a 5% chance of being pain-free. So patients come back to us again and again and again. And you see, in fact, that we have now a spectrum of how likely it is that we might be able to help patients depending on what is happening in the brainstem. And some of that we might see easily, such as an MS or a single ponting lesion. Some of that we might not be able to see easily. We would need to do advanced methods of imaging to distinguish that. So this really set the scene as to how we see this condition developing both at the level of the nerve, then in the brainstem, then in the white matter fibers, then in the brain. And slowly, we moved from just considering trigeminal neuralgia as a static condition that is looked after with a couple of operations, just go to the nerve, take the blood vessel away, to understanding that in fact the whole of the nervous system is involved and participates in the expression of pain and in the sort of dynamic nature that this pain has and how it integrates itself in the brain. So I now want to fast forward to where we are now to really talk about a couple of key concepts. And that is based on the work that we've done with the advanced brain imaging, I hope that I've imported that trigeminal neuralgia can be used as an excellent model to study neuropathic pain. And that the paths of inquiry have really linked the nerve and brain-related abnormalities and highlighted their importance. So now what do we do from this point? Now we have a whole lot of clinical data sets, a whole lot of large imaging data sets. You can see the number of data points that we can draw. And importantly, we have unequal data sets in both time and space. So it is upon encountering of this dilemma, an interesting question that needs to be studied, a clinical population that needs an answer, and us having all kinds of discrepant data, that we came to the use of AI as a perfectly suited methodology to answer these questions. And I have really the unique privilege of working with colleagues such as Frank Rudzik at the Vector Institute, and having trainees such as Tim Latipov as well as Marina Tofik, who have been instrumental in driving this work forwards. And I would like to share with you for the remainder of the time that we have, and I really apologize for our internet glitch, what we have been able to discover. So the very first AI path of inquiry was whether we could use brain imaging to predict pain, essentially answering the question of, are the changes in the trigeminal neuralgia brains unique enough that we're now able to distinguish or train a machine to distinguish pain versus non-pain. Again, remember the pictures that I showed you at the beginning, our concept of pain being eternally a subjective condition, and whether we're now able to use imaging to actually predict the presence of pain. And in fact, we can. So this was a study that we published in 2018. At the time, we felt, quite powerful with a training set of 45 and, leave one out cross validation. But despite that, we were actually quite good at distinguishing a TN versus non-TN with an individual likelihood of prediction that was in the high 80s, about 88%. So that was great. And then the field of AI and imaging just kept walking ahead of us. So I'll show you what we did next. Another key aspect that formed a path of inquiry for us was not so much looking at the different type of brain imaging, but focusing primarily on the brainstem and thinking, well, the trigeminal nerve fibers are right there. How are the trigeminal fibers helpful in determining whether it is likely for a patient to be pain-free after receiving treatment? And in order for us to do this study, We used brain imaging for patients that have not had treatment. So these are pre-treatment MRIs. And then we looked at their brainstem, at the trigeminal fibers in 3 zones, in the cisternal segment, root entry zone, as well as the ponting segment, and then looked at their clinical outcomes 1 year after treatment. And in fact, what we found is that those that are, if I can use the term loosely, destined to be responders, demonstrate microstructural changes that are restricted to the cisternal segment, whereas those that are going to be non-responders, in fact, appear to now have more of a centralized component. So we see microstructural changes within the segment of the pons, suggesting that as pain becomes more centralized, then it is less likely that it will be helped with a procedure that primarily affects root entry zone or periphery. And this fits again within that spectrum that I mentioned of the likelihood of response to treatment. We then looked at whether regional brain morphology would be able to predict pain relief in trigeminal neuralgia. And we did this looking again at the brain, at the central nervous system. And we had an SBM model for this to understand whether pre-treatment, again, regional brain morphology is able to predict relief. And our machine learning models are looking at regional brain gray morphology in patients that underwent gamma knife radiosurgery. And we were wondering whether this would give us same, better, or potentially worse prognostic performance than nerve-based models. Well, in fact, they give us a much superior prognostic performance. And we were able to achieve, when we use surface area measures, a cross-validated accuracy of 96%. And a key to this is that we were able to pull out the important features, neuroanatomical features that were contributing to this accuracy. And if we look at cortical thickness alone, we drop a bit, but we're still better than what we were before with an accuracy of about 90%. So again, this tells us that in fact, the brain has a very important role in the expression of pain. And the cards that are essentially turned backwards is again, not at the site of the blood vessel or compression of the blood vessel necessarily where we need to focus. So then let's look at all of these put together. We have the brainstem, we have the cortex, and each of these in these conditions are contributors to our understanding of whether a patient can be a responder or a non-responder. So in patients that have classical trigeminal neuralgia, the vast majority of these patients do respond well to treatment. MS-related trigeminal neuralgia, they have lesions in the brain, not so much. And again, single ponting lesion. But remember, this group, the red bunch of the classical trigeminal neuralgia that do not respond, are the ones that are likely to have microstructural changes within their brainstem. So we now have a unique situation. We want to understand and we want to have advanced brain imaging and these paths of inquiry to converge in this large collection of data that cannot be used or properly studied using conventional statistics. So based on this, we have moved to the use of Gaussian process characterization of group trigeminal fibers. And in this work, we have been able to pool large numbers of fibers from multiple patients. So rather than using one person studying their metrics and go to the next, we have actually pooled them and used this information to study the fibers of the trigeminal system as they course through the brainstem and beyond, and draw data from this to distinguish, again, classical trigeminal neuralgia from other conditions and distinguish them such. Another important work that is part of the work that Tim Blatikoff and Marina Tawfiq are involved in is really an upscale from our very initial machine learning study. So rather than now focusing on just a few patients, we have a very large data set of well over 500 images. And what we want to understand is whether this large and unequal data set is able to discriminate pain versus non-pain states. So for this, we have used two different models, random forest as well as logistic regression, with a very high accuracy of prediction of pain. And we can distinguish pain from non-pain quite easily. We, in fact, looked at two different pain conditions, and although we are able to pull the key neuroanatomical regions that are different in each, in terms of prediction, we do not have the sufficient discrimination to distinguish between two different pain syndromes that affect the face. Nonetheless, our work and our ability to predict pain versus non-pain holds very much, and in fact, I would say is much stronger than our very initial publication. So talking about unequal data sets, we in fact came upon this very problem of having variations in imaging parameters and sequences. We rely quite a lot on diffusion images, and many of our patients have had images elsewhere, and they have not had the type of sequences that we need. So this really moved us to address this problem of difficulty in cross-comparing MRI images in different that have been acquired in different machines. And we're now involved in using generative adversarial networks to really draw synthetic, realistic MR images based on previously acquired MR sequences. So this is a highly attractive project, and it's the work that is now funded by TCARM and CFAR, and we're very excited to be participating in this. And these are some of our results showing, maybe I won't tell you which one's which, top or bottom, which one's acquired and which one is a synthetic. But you can tell that in fact they look very good, and this is diffusion images that I'm comparing for you. And this is our pipeline, the MR data sets that are processed from over 2,000 subjects, and then artificial DTI as well as T1 data can be taken from these images and then compared with real data. The last study that I wanted to share with you is very interesting in that it points to how essentially our whole system reacts when we are in pain. It turns out that if we put together a machine learning algorithm, we are able to use brain MRIs that can correlate chronological age with predicted age. And that means that if we fall on the identical line that most patients actually do, if I am, I don't know, 35, then I would have my brain predicted age would be 35. If I'm 60, my brain predicted age would be 60, and so on. So this is obviously great. It's very interesting. There's many people that have put together such studies. We have as well. But when we map patients that have trigeminal neuralgia onto this model, we find that in fact patients that have trigeminal neuralgia are quite a lot older. At the very least, anywhere between 10 to 14 years older. And this was obviously very interesting for us. We used different pain syndromes to look at this type of accelerated brain aging. And we see that it affects syndromes in an unequal manner. Patients with trigeminal neuralgia and osteoarthritis, for instance, express significant brain age gap estimate, but those with back pain do not. And the effect is chiefly driven by women, suggesting that in fact this what we're looking at, and chronic pain and sex is something that we're well aware of, that there's an interaction between them, but also suggest that the way we approach the study of pain, the way we collect patient data and pull together, needs to take this into account as well. So all roads lead to Rome. Multiple paths of investigation in the field of pain have been informed by brain imaging as well as AI, and they all converge into the goal of greater objectivity in our understanding of pain. I expect that this will directly translate into clinical benefit and allow us to diagnose and make treatment decisions that are better for patients, and importantly, individualize them for their specific benefit. AI really provides us with a unique advantage in allowing a framework of analysis that really would otherwise be impossible. I hope that you agree with me on that account. And our impact, although our field of work right now is trigeminal neuralgia, will lend itself to other forms of pain, and hopefully understanding and management of other forms of pain as well. So this is just one syndrome, one nerve, in fact, that I've spent an hour talking about that has a number of syndromes. You can see this is the classic chart that you would find in the textbook. What is the pain like? What do we presume is the cause? Are there sensory changes or not? Imaging is nowhere to be found, and diagnosis is based on clinical grounds alone. What we want to do is really to move beyond clinical criteria as the sole identifiers of these syndromes, and have something that is able to supplement our clinical understanding and provide objectivity in the work that we do. So I want to thank you again for giving me this opportunity. I'm really, really fortunate to have amazing colleagues and collaborators, graduate students, postdoctoral fellows, research staff that work with me in these projects. And there is hopefully a little bit of time for questions. Thank you again for asking me to participate.
Thank you so much, Dr. Hodaie, for that really fascinating talk. So we do have two questions. One of them came in when people registered, and I think it's a very nice analog to how you're talking about how trigeminal neuralgia can teach us a lot beyond just the facial nerves. Can AI help in predicting the transition from acute pain to chronic pain, such as through brain mapping?
Yeah, that's very interesting. So we have not studied acute pain. I guess maybe initially I used the example of a paper cut. I think paper cut is actually an excellent model for that. As tiny as it is, we've all felt it, and it feels rather intense. But in fact, there are neuroanatomical changes that distinguish acute pain from chronic pain. And therefore, if we and when we are able to reach a point in which we are able to use AI with greater clinical comfort in diagnosing and prognosing patients, then I suspect that the transition between the transition between acute and chronic pain will also become more possible, more comfortable, and it's actually very relevant. The treatments that we have for acute pain are very different than what we have for chronic pain. The whole diagnosis of acute versus chronic has many, many implications. So this would be a very important field of study, and I hope that our work will lend to that as well.
Wonderful. We also got a question in the Q&A. What proportion of people with TN have no vascular compression?
So the proportion nears 40%. It's sizable. Now, one could say that some of these studies are older. Maybe the MR imaging was not as accurate. That's certainly a possibility. I would suggest that an MRI looks only at certain things. It's, the typical analogy that I use is that, we're looking at a landmass from an airplane. We see a lot. We can even see cars. And, we might be able to see people, but beyond that, there's only so much more that we can tell. So oftentimes when we operate on these patients, in fact, we see there might not be a very obvious level of compression, but we all have this, web of arachnoid that is present in our central nervous system and covers the structure of our brain. And sometimes the arachnoid is tight and is holding the nerve down. But you might look at the MRI and not see that and presume that in fact the nerve is free. Well, the nerve might be free of a vessel, but that's our imaging limitation. So is the number of, almost 40% accurate? Maybe, maybe not. But isn't that the problem? That we rely on the visualization of a corollary to make that diagnosis. And we don't have anything better than that. I think 2022 and onwards, we really owe that to our patients. I don't speak with families, with patients by showing them an MRI and say, well, I think there might be a tumor in there. I'm going to go find out. We owe them a greater level of certainty, and we do really good imaging to be able to give them that answer. The same is true with patients with trigeminal neuralgia. For me to say, well, I think there's a vessel there, let me go find out, is quite a task to ask a patient to undertake. But they do that because their pain is so severe. But having spoken with many, many of these patients, I really wish to have a better way of having this clinical discussion with them and have a better diagnosis for their conditions.
That's a wonderful place to leave it. Unfortunately, it looks like we are at time. There are some other questions that came in the chat, but perhaps those of you with questions can reach out to Dr. Hodaie directly via email. I'm sure she'd be very happy to continue this conversation. Thank you everyone for attending this talk. Please keep up to date by following us on Twitter at UFT_TCarum and subscribing to our mailing list on our website. Thank you all very much. See you soon. Have a wonderful long weekend. Take care.
Bye, everyone.